So good afternoon all. Today we'll be discussing a case of anemia in pregnancy. Our patient's name is Ponni. She's a 24-year-old female hailing from Attapadi. She's a homemaker and her educational qualification is 6th standard. Her obstetric score is G4P3L2A1 and her gestational age is 36 weeks. She's married to Mr. Raku, who's a manual laborer. Her presenting complaints are easy fatigability since past 2 months, palpitation since past 2 months, and increase in swelling on both legs since past 2 months. History of present illness. History of present illness. She's a 24-year-old female patient of obstetric score G4P3L2A1 with complaints of easy fatigability since past 2 months, progressively increasing in intensity and relieving with rest. It is associated with palpitation, which is increasingly felt with exertion and which is relieved with rest and sleep. It is also associated with bilateral pedal edema, progressive, aggravated on prolonged standing, decreasing with rest as well as foot end elevation. It is not associated with syncope, chest pain, paroxysmal nocturnal dyspnea. There is no history of generalized swelling, headache or blurring of vision. There is no history of cough with expectoration, hemoptysis, evening rise of temperature. There is no history of bleeding per vaginum or leaking per vaginum. There is no history of passing of worms in the stools. There is no history of bleeding per rectum, melena or hematemesis. There is no history of fever with chills, hematuria or burning micturition. There is no history of yellowish discoloration of skin or sclera. History of present pregnancy, first trimester. Her urine pregnancy test was positive on 26th of December 2020, 2 weeks after missing periods. She was on regular antenatal checkups from a nearby PSC. She gives history of hospital admission for hyperemesis gravidarum. She has taken 2 doses of tetanus toxoid injection. Folic acid tablets were not taken regularly. She doesn't give any history of bleeding per vaginum, abdominal pain, fever with rash, urinary tract infection, radiation exposure, or drug intake. USG, which was done at 11 weeks of gestation, was found to be normal. Second trimester, quickening was felt at 4.5 months. Anomaly scan done at 20 weeks was found to be normal. 75-gram glucose tolerance test done was normal. She gives history of irregular intake of iron, folic acid, and calcium tablets in the second trimester. There is no history of gestational diabetes mellitus, gestational hypertension, bleeding PV, or leaking PV. Third trimester, patient appreciates adequate fetal movements. There is no history of gestational diabetes mellitus, gestational hypertension, bleeding PV, or leaking PV, or abdominal pain in the third trimester. Ultrasound scan done during present admission reported that fetal growth did not correspond to gestational age. Past obstetric history. Her obstetric score is G4P3L2A1. She had a full term of her first and third pregnancy was full term normal vaginal delivery. Second pregnancy, she had a spontaneous abortion at 2 months of gestational age. She also gives history of anemia in the third pregnancy, requiring one unit of blood transfusion at 37 weeks of gestation. The baby born during this pregnancy was of low birth weight and she weighed 2.3 kgs. Menstrual history. Her LMP was on 11th of November 2020. She attained menarche at 14 years of age. She had regular 28 to 30 day cycles with 6 days of menstrual flow. She doesn't give any history of dysmenorrhea or menorrhagia. Marital history. It is a non-consanguineous marriage at the age of 17 years. There is no history of contraceptive use. Past history, there is no history of diabetes, hypertension, coronary artery disease, cerebrovascular accidents, bronchial asthma, pulmonary TB, jaundice, seizures, measles, mumps or chickenpox in the past. No history of previous surgery, drug or food allergy in the past. No history of COVID-19 infection or recent respiratory tract infection. Family history. There is no history of diabetes mellitus, hypertension, heart disease, bronchial asthma, malignancy, abortions, or congenital anomalies running in the family. Personal history, her sleep is normal. She is a non-vegetarian. Her appetite is normal. Her bowel and bladder habits are normal. There are no addictions. Socioeconomic status, she is hailing from a below poverty line family.
Okay, we'll stop there for a minute. Okay. Can you hear me?
Yes, sir.
Okay. Your patient was a G4P3L2A1. What is the impact of multiple pregnancies on patient's status?
Multiple closely spaced pregnancies can result in decreased iron stores and there is increased incidence of iron deficiency anemia due to decreased tissue stores and also because of prolonged lactation.
Okay. In your history, you said this patient has got fatigue, palpitation, and pedal edema. I'm telling you that this patient has got congestive cardiac failure. Do you think a patient has got congestive cardiac failure? If yes, what are the things that are for yes? If no, what are the things that are for no?
As of now, she doesn't have congestive cardiac failure because there is no dyspnea on exertion. She doesn't have orthopnea, paroxysmal nocturnal dyspnea, etc., which points towards cardiac failure.
How do you explain the pedal edema?
Pedal edema, it is normally present during pregnancy because of the gravid uterus compressing on the IVC, causing increased venous pressure, stasis, and pedal edema. Also, because of hypoalbuminemia associated with anemia, patient could be developing pedal edema.
Would a history of drug intake have any significance in this patient?
Irregular iron intake.
NSAIDs. NSAIDs.
NSAIDs.
Can bleeding.
GA, please.
Correct. So what are the other drugs that they can take that could possibly block iron absorption?
Tea and drinks such as phytates, tannins, phosphates, etc. can decrease iron absorption.
Okay.
Other drugs which can cause anemia include anticonvulsants such as carbamazepine, phenobarbital, indomethacin, aspirin, then anti-thyroid drugs, anti-neoplastic drugs. All these drugs can cause anemia.
Why do this pregnant patient normally get anemic?
Because of physiological anemia of pregnancy. During pregnancy, after 6th week of gestation, there is increase in plasma volume of about 40 to 50%, and increase in red blood cell mass is about 20 to 30%. So there is disproportionate increase of plasma volume compared to RBCs. As a result, there is hemodilution and physiological anemia of pregnancy.
So if the patient becomes anemic, does she decrease giving oxygen to the baby, to the fetus?
Yes, sir. No, sir. No, sir.
The fetus, delivery of the oxygen to the fetus is always maintained.
Okay, how does that happen? Why does that happen? Although the patient is anemic, when they become anemic, they'll carry lesser oxygen. So how do they maintain adequate oxygenation to the fetus?
The sympathetic drive in the maternal circulation is increased as it increases.
What happens specifically on the ODC?
ODC shifted towards the right side. Side, so that more oxygen
is
released from the hemoglobin.
ODC shifts in the right in whom? The mother or the fetus?
In the mother, ODC is shifted to the right, so it increases the release of oxygen from the hemoglobin.
What happens in the fetus?
In the fetal side, there will be shift of the ODC to the left, which increases the affinity of the oxygen to hemoglobin.
So what is this known as shift to right in the mother and to left?
Double Bohr effect.
Okay, madam, your questions, madam.
Okay. Friend Swati, now you have the provisional diagnosis of anemia, isn't it? So what are in a pregnant patient? That is, how can you prevent anemia in a pregnant patient?
We should give adequate dietary supplements in food. We must give her adequate diet. Also, we should give oral iron and folic acids. Folic acid tablets should be ideally started 3 months pre-conception, and it has to be continued throughout the pregnancy and postpartum. Iron and calcium tablets are usually started in the 2nd trimester, and it is continued. It is the best thing is to continue iron for 1 year postpartum in view of lactation.
Oh, so you consider this as iron deficiency anemia. So what are the other causes of anemia?
Anemia, causes of anemia can be
classified pregnant patients.
In a pregnant patient, there will be physiological anemia of pregnancy due to the increase in intravascular volume and disproportionate increase in the intravascular volume and increase in the RBC volume of 20 to 30%. And
Okay.
a nutritional deficiency during in early trimesters, patient may have decreased intake of iron containing foods due to hyperemesis gravidora, as well as irregular intake of iron tablets throughout the pregnancy. And multiple pregnancies with inter-pregnancy gap of reduced inter-pregnancy gap can lead to anemia due to increased requirement of iron and depletion of the iron stores in the maternal body.
Also,
What
there
are
are
the other
other
causes?
causes such as
What are the other causes of
hemorrhagic-
anemia?
pathological anemia due to hemorrhagic causes, which may be either chronic hemorrhage, such as due to hookworm infestation, or hemorrhoids, acute blood loss, which can occur in antepartum hemorrhage. Then other causes are bone marrow depression, which can be due to aplastic anemia, parvovirus B19 infection.
Okay, that we can discuss later. So why the anemia is significant in a pregnant patient? What are the effects of anemia in a patient as well as in the fetus?
Anemia causes many complications in the mother as well as in the fetus. In the mother, in the antepartum period, patient may go for cardiac failure in the 32 weeks of pregnancy and can have infections, antepartum hemorrhages, preeclampsia, preterm labor, abruptio placenta, during labor, patient will not be able to compensate for the blood loss during delivery, and patient can go for a uterine atony, postpartum hemorrhage and shock, and also infection during infection. And in puerperal period, puerperal sepsis, thromboembolism, thromboembolism, and subinvolution of the uterus can occur. And in fetus intrauterine growth retardation, intrauterine death, stillbirth, and fetal distress, fetal hypoxia, and the fetal acidosis can have, and fetus will have congenital malformation of the fetus. And in neonates, in neonatal period, baby can have anemia, and in congenital malformations, cardiac defects, and delayed baby.
What happens to the Apgar score in the delivery?
Poor Apgar
score, as well as it can also cause fetal distress. Okay. Okay, sir, you can continue with the questions.
Yeah, let them finish their clinical findings presentation and then we'll continue.
Yeah, okay, sir. An examination, what are your examination details?
General examination. The patient is conscious or oriented in time, place, and person. She is moderately built and nourished. Her height is 150 centimeter. Her weight is 52 kg. Her BMI is 23. Pre-pregnant weight is 45 kg and weight gain during pregnancy is 7 kgs. She was found to have pallor and bilateral pitting pedal edema. There is no icterus, cyanosis, clubbing, lymphadenopathy. Her skin is pale. Her nails have vertical ridges. Head to foot examination was found to be normal, and there is no spinal tenderness. Vital examination. Her pulse rate is 96 per minute, regular in rhythm, normal in character, no radioradial or radiofemoral delay. All peripheral pulses are felt equally and bilaterally. Her BP is 108/76 millimeters of mercury, recorded in the right upper limb in sitting position. She is afebrile. Her respiratory rate is 24 per minute and it is regular. Airway examination. Her mouth opening is more than 3 fingers. Thyromental distance is 3 fingers. Thyromental joint can insinuate 1 finger. Her modified malleability classification is 2. There is no loose tooth, artificial tooth, or buck tooth. Neck movements are within normal limits. Obstetric examination. On inspection, her abdomen is longitudinally distended. Flanks are not full. Umbilicus is everted. Stria gravidarum and linea nigra are present. Hernial orifices are normal. No engorged veins are seen. On palpation with legs in semi-flexed position, fundal height corresponds to 32 weeks. Symphysia fundal height is 33 centimeter. Abdominal girth is 97 centimeters. Fundal grip, there is a broad, soft, irregular, non-palatable mass suggestive of breach is palpable. On umbilical grip, firm, non-uniform resistance is felt over left side, which is suggestive of baby's back. Multiple nodules suggestive of limbs are palpable on the right side. First pelvic grip, there is a hard, round, freely mobile palatable mass, which is suggestive of head, that is cephalic presentation palpable. Second pelvic grip, there is occiput is at a lower level compared to sinciput, hence it is a flexed head, which is not engaged. On auscultation, fetal heart rate is 142 per minute regular, obtained over left side inferior to the umbilicus. Other system examinations, cardiovascular system, a pulse rate is 96 beats per minute, regular in rhythm, normal in volume character, no radioradial or radiofemoral delay. All peripheral pulses are felt equally and bilaterally. Vessel wall is not palpable. BP 108 by 76 millimeters of mercury in right upper limb in sitting position. JVP is not elevated. Inspection. Shape of precordium is normal. There is no precordial bulge or chest deformities. Apical impulse is not seen. No other visible pulsations, engorged veins or pigmentation. There is no scars, sinuses or accessory nipple. Palpation. Apex beat is felt in the fourth left intercostal space lateral to midclavicular line. There is no palpable P2 or left parasternal heel. No thrill or other palpable pulsations. Percussion. Liver dullness is felt in the fourth right intercostal space. Right heart border corresponds to right border of the sternum. Left heart border corresponds to apex. Second left intercostal space dullness is normally felt. Auscultation. First and second heart sound is normally heard. Ejection systolic murmur of grade 3 is heard in the aortic area. There is no radiation. No adventitious sounds such as clicks or rubs are heard. Gastrointestinal tract with the normal limits. Respiratory system with the normal limits, and central nervous system is within normal limits. Summary. She's a 24-year-old female with obstetric score of G4 PP3 L2 A1 with gestational age 36 weeks, hailing from a socioeconomically backward family. She complains of easy fatigability, dyspnea on exertion, and palpitation for past 2 months. She gives history of irregular intake of iron and folic acid tablets. Third trimester ultrasound scan shows fetal growth restriction. She also gives history of multiple closely spaced pregnancies at a very early age. She gives history of anemia requiring blood transfusion in the third pregnancy. The same pregnancy, the baby born in the same pregnancy was of low birth weight, weighing 2.3 kgs. On examination, she is poorly nourished, has pallor, vertical ridges in the nail, and ejection systolic murmur in the aortic area. There is also poor weight gain during present pregnancy, and the size of uterus doesn't correspond to gestational age. Our provisional diagnosis is 24-year-old female patient of obstetric score G4P3L2A1 with a gestational age of 36 weeks. Came with anemia complicating pregnancy, which may be probably due to iron deficiency.
Okay, you had a murmur in the aortic area, 3/6. You think that's aortic stenosis?
No, sir.
Why?
It could a grade 3 murmur could be normally heard in pregnancy, or it could be a functional murmur due to anemia, sir.
Okay. Why do RBCs have such a short lifespan of 120 days?
RBC doesn't have a nucleus, so it will not be able to produce the proteins for the lifespan. So it loses the structural integrity within 120 days and it dies.
Very good. But during all their stages of development, do RBCs not have nucleus?
No,
No,
sir.
up to normoblastic stage, the RBCs will have nucleus. After that, reticulocyte and erythrocytes will not be having nucleus.
So this erythroblast stage, is that in blood or is that in bone marrow?
Bone marrow.
Okay. So that's the reason why you need to start early B12 and folic acid when the nucleus is there. Okay. So the other thing you want to know, some examiners like to ask is, they like to ask how is the iron absorbed, where is it taken, what is the role of transferrin and all that. I think we'll leave that out. All exam going PGs, please read it up. The examiner might be interested. We'll concentrate more on the clinical examination and the investigation. What type of circulation do you normally see in anemia?
Hyperdynamic circulation is normally
Yes,
seen.
you see a hyperdynamic circulation. Will the systolic BP be normal?
No, sir. Systolic BP as well as diastolic BP will be reduced, but the reduction in diastolic BP is more than systolic BP. As a result, there will be a wide pulse pressure and a high bounding pulse.
Very good. Most of the vital organs have got an autoregulation. What is the autoregulation values for placental circulation? See, for example, let's say heart.
No autoregulation. Placental circulation is not autoregulated, sir.
So it is not autoregulated.
It's a low resistance circulation.
Very good. So that is why you have to make sure that you maintain the BP is normal. That is why the DPP has to be low. Is there any other circulation that does not have autoregulation?
Portal
Very good, very good.
Liver.
There are only two things that don't have. Portal and placental circulation do not have autoregulation. So how many molecules of oxygen can a molecule of hemoglobin carry?
One molecule of hemoglobin can carry 4 molecules of oxygen. 4 molecules of oxygen, sir, because hemoglobin
that is provided it is an normal adult hemoglobin.
Okay, adult hemoglobin of HB.
Correct. There are different kinds of hemoglobin. Madam, you want to take that topic up, madam?
Okay. So the 4 molecules of molecules. So what are the abnormalities among the causes of anemia? What are the other hereditary causes of anemia?
Other hereditary hemoglobinopathies including sickle cell anemia and thalassemia, and hemolytic anemia. And sickle cell anemia.
So what is this sickle cell anemia? What is the changes that is happening in the hemoglobin?
It's an autosomal recessive congenital hereditary congenital hemoglobinopathy in which glutamic acid in the 6th chain of the globin is replaced by valine. And
Yes, okay.
due to that, in deoxygenated state, hemoglobin will be clumped together, which results in sickling, and it results in hemolysis and causing hemolytic anemia. During anesthesia, while giving anesthesia, the thing which we have to see is we should avoid hypoxia, hypovolemia, hypothermia, and pain and acidosis.
Okay, what happens in thalassemia? What are the changes that can occur in the hemoglobin in thalassemia?
Thalassemia is an autosomal codominant condition in which there will be decreased or absence of synthesis of either one or more of the globin chains. It is of 2 types: thalassemia major, in which patient won't survive long, and in thalassemia minor, in which decreased synthesis of one or more globin chains. The patient will be having recurrent episodes of hemolytic anemias, and due to ineffective erythropoiesis and clinical features of frontal bossing and malar prominence and all will be there. Due to this repetitive recurrent episodes of anemia, patient will be having multiple blood transfusions, which results in iron overload in the patient. And for this also, we have to avoid, while giving anesthesia, we have to avoid hypoxia and hypothermia and all.
So when will you treat this thalassemia? What will be the approximate hemoglobin level? In mild cases, usually it is not required, but in we can treat it by vitamins as well as some forms. Some forms only requires blood transfusion as a blood as from the donor, or the maximum treatment that we can offer to a patient with the thalassemia is what? That is from the donor stem cell transplant. So that's why in the history itself, you have said that there is no history of any hereditary diseases in the family happening in the hemoglobin molecules because of that. Okay, sir. Sir, you continue, sir.
Okay, what basic investigation would you like, doctor? Although it's not our domain, usually the obstetricians bring an investigated case to us. But what investigation do you normally look for in this patient?
In this patient, we can do a routine CBC with the hemoglobin and hematocrit. Along with that, we can do a peripheral blood smear. Since this is an iron deficiency anemia, it will reveal microcytic hypochromic anemia with anisocytosis and poikilocytosis. Also, in the peripheral blood smear, we can look for reticulocytes and malarial parasites.
What is normal reticulocyte count?
It is 0.2 to 2%.
If it is increases, a good thing, or is it bad thing if it increases?
If it is increasing, it is a good thing, sir. It shows response to treatment, sir.
Very good. So total iron will be decreased, ferritin will be decreased. Okay. Total iron binding capacity will be
increased more than 400.
Yeah. Transferrin saturation will be
decreased less than 15%.
Very good. This is classical for iron deficiency anemia. What is RBC distribution width?
It is an investigation to look for the variability in the RBC sizes. Increased red cell distribution width is indicative of an isocytosis, that is iron deficiency anemia. It is increased in iron deficiency anemia.
In iron deficiency, in folate deficiency, and in vitamin B12 deficiency, in all of them, the RBC distribution width will be increased. In all other anemias, it tends to be normal. Okay, so that's all you need to remember. Our RW, will be increased. Would you like to do a renal function test in your patient?
Yes, sir. Chronic renal failure can present with anemia of chronic disease. So
if a patient had anemia due to chronic diseases, how much of iron should you give this patient to actually treat him? Will iron help?
We must also, along with iron, we must also administer erythropoietin injections.
Correct.
At a dose of 150 international units per kilogram up to 4 weeks.
What is the side effect of starting erythropoietin on a patient?
It can cause hypertension and thrombosis.
Very good. So if a patient came with suspected sickle cell or thalassemia, what investigation would you do?
We can do a hemoglobin electrophoresis.
Very good. And do you think ECG and echo are mandatory for your patient?
No,
Anemia?
sir, it is not mandatory. Only if the patient is having any kind of, since this is a pregnant patient.
Your patient has got palpitation, your patient has got pedal edema. You know, it's so easy to confuse it with a congestive cardiac failure. Why don't you want an echo?
Baseline ECG can be taken to rule out the underlying MI or something.
Ischemic heart disease can be there. And also there seems to be an association with cardiomyopathies and anemia. So it might be good to do a screening echo. So I think that might be a safe thing to do. Okay. So that is your basic investigation that you're going to do. We have already discussed that we are going to basically treat this patient with oral iron and folic acid. Actually, the daily requirement of iron is only 10 milligram. Why do you give a dose of about 60 milligram elemental iron?
Only 10% is absorbed from the.
Very good. And what is the commonest reason why patients do not take their tablets regularly? This patient also did not take her tablets regularly.
Because there is high incidence of gastrointestinal side effects like nausea, vomiting, and dyspepsia, etc. Constipation.
And abdominal pain, abdominal cramps, all are very high. So that's why they generally default on this tablet. So if they don't take tablets and they come to you with anemia a little later in pregnancy, what are the treatment options?
Later in pregnancy, it is better to either supplement iron using parenteral therapy.
Madam, you please take that up, madam.
Parenteral iron therapy or,
yes. How will you give?
There are
parenteral iron.
Parenteral iron. There are IM or IV preparations. First, we will calculate the dose of parenteral iron by the formula 50 minus hemoglobin into body weight into 2.23. This is the total dose that has to be administered. It can either be administered as IM or IV. IM preparation that is available is iron sorbitate citrate or Jactofer, where we give a 75 mg IM in the right upper outer quadrant of the buttocks in a Z-track manner. Then it is the dose is 75 mg. It can be either repeated every 2 days, that is 3 times in a week, can be administered at a dose of 3 times in a week. Other iron preparations available are iron dextran, which can be administered as IM or IV. The doses, it is available as 50 mg per ml 50 mg per ml with 1 or 2 ml.
So what will you do if you have decided to give IV of iron? What will you continue with the oral iron?
No, sir. No, madam. We will stop oral iron at least 24 hours prior to IV parenteral iron administration.
Why?
This
blocks the
receptors. Also, there is high incidence of anaphylactic.
Yes, the absorption can be decreased, so the chance of toxicity will be there. So, so what are the indications of this parenteral iron?
Parenteral iron is given where in case of intolerance of oral iron, non-compliance of oral iron towards the term of pregnancy, or if the patient is having any sort of malabsorption, or if the patient is having antepartum hemorrhage. In all these conditions, we'll give parenteral iron, madam.
And also in women nearing term, where we are not getting enough time to correct the anemia. So, which are the common preparations of parenteral iron?
Iron dextran is iron sorbitol citrate is IM form. IV forms
Yes.
are iron dextran, iron sucrose, iron 3 carboxymaltose, iron isomaltoside, and ferrum oxetol. These are the IV preparations.
So what is the common drug that we usually give?
Iron sucrose is the drug that we usually give
And
because
what is the dose of it?
iron sucrose, it is available in 20 mg per ml 5 vials containing 5 ml of the solution. It is diluted in 100 ml of normal saline and it is given over 20 to 30 minutes.
Yes, the period is also important. So use it. The other preparations are ferric carboxymaltose and iron isomaltose like that, isn't it? So what are the advantages of that?
It increases hemoglobin at a rapid rate. That is, there is an increase of 2 gram per deciliter per week compared
Yes.
to the other iron formulation, which increases only 0.7 gram per week.
Sir, you can continue, sir.
Yeah. So we looked at this patient who was probably 36 weeks, not been taking iron properly. And even in a previous pregnancy, she has had anemia. Do you think this is acute anemia or chronic anemia?
Chronic
Yeah,
anemia.
it's a chronic anemia. So in chronic anemia, there are certain compensatory mechanisms that ensure that oxygen carriage is maintained. What are the compensatory mechanisms?
A compensating mechanism in mother includes there will be increased sympathetic drive causing increase in the cardiac output, decreased viscosity of the blood to maintain the patency of uteroplacental blood circulation, and increase in the 2,3 BPG level, and increase in the erythropoietin, and increase in oxygen extraction, increase in RAS mechanism, and hemorrheology also will be altered for the transport of RBC through the minute capillaries.
Will these compensatory mechanisms occur for, say, example, in a case of APH where there's acute blood loss?
No, sir.
Yeah, unlikely to occur. So these are all compensations that occur only in chronic anemia. So in anemia, the basic problem seems to be oxygen delivery. That's what we are focused on, both to the mother and to the fetus. So how is the oxygen basically transported?
Oxygen is transported in two forms. 97% of oxygen, it is transported bound to hemoglobin, and rest 3% is transported bound to dissolved in plasma.
So the bound to oxygen form is called as the convective transport of oxygen, and the dissolved form is called as the diffusive transport of oxygen. Okay. So what happens to the delivery of oxygen in anemia? DO2. What is DO2 first? How do you calculate DO2?
DO2 is equal to cardiac output into arterial oxygen content.
But how is the arterial oxygen content come about?
Oxygen content is equal to hemoglobin into 1.34 ml, which is the Huffner's constant. That is the amount of oxygen that is bound to 1 gram of hemoglobin into saturation plus 0.003 ml of oxygen into PO2 is the arterial oxygen.
It is saturation divided by 100. Okay, because that's as a percentage. So you don't multiply it into 100. So you do it 100 by 100. Okay, that alone you need to do. So CaO2 into cardiac output is the DO2. That's delivery of oxygen. How much of oxygen is delivered?
1000 ml per minute is delivered.
Okay, what is the oxygen content for 100 ml of blood that goes out of the heart?
It is if a saturation is 99 and hemoglobin is 15, then it is 20 ml.
Yeah, roughly about 20 ml, just a little less than 20 ml. Then what is this VO2?
Oxygen consumption.
Correct. So how much of oxygen is actually consumed at tissue level?
ml per minute.
So how much of oxygen, the returned blood that comes onto the venous side, to the right side of the heart, does it contain oxygen or does not contain oxygen?
It contains 75% of oxygen.
How much ml is that roughly?
750 ml.
Yeah, so 15 ml is there. So what goes out on the arterial side is 20 ml. What comes in the venous side is 15 ml. So only about 5.5 ml is used at the tissue level. So normal oxygen extraction ratio is?
It's the ratio of VO2 by DO2, which is of 25%.
Very good. So what is critical DO2?
Critical DO2 is the point at which there is no compensatory mechanisms occurs to meet the increased oxygen demand.
Okay,
That is below with which cell anaerobic mechanism sets in, and products of anaerobic mechanism will start accumulating in the cells like lactate.
Very good. So above the critical DO2, the VO2 is independent of the DO2. Even if the DO2 comes down a little or goes up a little, the VO2 will remain normal. But when you go down below the critical DO2, for every decrease in DO2, the VO2 will also start increasing, and that will cause a problem about delivery to the tissues. There are two tissues in the body that cannot increase the oxygen extraction. Most of the other tissues, even if the DO2 comes down, they'll extract more oxygen out. There are two tissues that cannot extract oxygen out. Which are the two tissues more prone to hypoxic injuries?
Heart is there. Heart and brain.
Very good. Heart and brain, they have very poor reserve of oxygen. At the same time, they cannot increase their oxygen reserve, because of which you have to be very, very careful about how you deliver oxygen to these two tissues. Okay. What is Bohr effect?
At the tissue level, there will be increased partial pressure of carbon dioxide and acidosis will be there. So the affinity of the hemoglobin to oxygen will be decreased, and O2 is released more to the tissues.
Okay. What is Haldane effect?
Haldane effect is in the lungs. There will be increased oxygen level, so that the affinity of the hemoglobin to the carbon dioxide is decreased, and increased unloading of the carbon dioxide occurs in lungs.
What is the least amount of hemoglobin that is needed for critically for life to be sustained?
2 to 3 grams.
Yeah, 2 to 3 grams per deciliter is this thing. But if a patient came with zero hemoglobin, is there any way you can sustain life?
You can give
it's an abstract out of the box question.
You can give hyperbaric oxygen, or you can increase the FiO2.
Correct. If you give 100% oxygen at 380A in a hyperbaric chamber, that is 760 into 3, the dissolved oxygen will be more than 5.5 liters. It can take care of all the requirements of the body. So that's the only way to survive if you don't have hemoglobin. So we are not going to do all of those things. If a patient at say 38 weeks came, it is too late to give IV hemoglobin and make her all right for anesthesia. So what are the options that is there with such a short time for you?
We can give blood transfusion.
Okay. So normally for non-pregnant patients, the trigger is below 6 gram deciliter, you give transfusion. Above 10, you don't give blood transfusion. At your institute, what is the value you want before you take a patient up for elective LSCS? At your institute?
At our institute, we recommend a hemoglobin level of 9 gram per deciliter before taking them for elective LSCS.
Okay. So this is little, each examiner may have a different value in their mind. So stick to what your hospital protocol is, because in my hospital, the protocol is 8.5. We accepted 8.5. Madam, you can take it up from here, madam. Blood transfusion and management.
So what are the goals of blood transfusion?
Goals of blood transfusion is to increase the oxygen carrying capacity of blood. Since the patient is having low hemoglobin, giving blood transfusion increases the hemoglobin level, and the patient will not go for decompensation during the increased blood loss during delivery.
So how will you give blood? You are planning to give whole blood or blood components?
So we give blood components. We give packed RBCs. We are planning for electives. Yes, it is to be given at least 24 hours prior to the cesarean section to normalize the 2-3 DPG levels, and also to watch for any hemolytic reactions such as transfusion associated cardiac overload or transfusion associated lung injury.
Yes. What is it, transfusion associated cardiac overload?
It is if after within 6 hours or within or after 6 hours of blood transfusion, if the patient develops any 3 of the following 6 criteria, it is called transfusion associated circulatory overload. The 6 criteria include acute respiratory distress in the patient characterized by dyspnea, orthopnea, etc. Then increased BNP levels, increased increased central venous pressure, evidence of left heart failure, evidence of positive fluid balance, or if the patient is having pulmonary edema. These are the 6 criteria. If the patient is having 3 or more of these, the patient is said to have transfusion associated cardiac circulatory overload.
So what are the usual reactions that you can expect?
After blood transfusion, you can get circulatory overload. You can get increased levels of decreased levels of 2,3 DPG. There could be hyperkalemia, hypocalcemia. The patient can develop infections, transfusion-associated lung injury, etc.
As well as the
Citrate toxicity.
you have to be very careful when you start with the blood transfusion in a patient, because you have to double check all the factors, whether that blood is belong to the patient itself, because in a pregnancy, it is very, very important. Okay. So do you want, when you give packed RBCs, do you want to give any plasma with that?
No, because since this patient is pregnancy is a hypercoagulable condition, it is not necessary that you give FFP for every packed RBC that we administer.
What's the normal, if it is a non-predicted patient, what is our
at a proportion ratio of 1:1:1, that is 1 PRBC, we give 1 FFP and 1 platelet concentrate.
Okay. Sorry, continue. Sorry, you continue, sir.
Yeah. So there's two important take-home points. If your obstetrician is giving blood transfusion, make sure it's completed 24 hours before surgery, because then you have a transfusion-associated circulatory overload. You put the patient in, you preload the patient and give spinal, and the patient goes in for pulmonary edema. You don't know what's happening. So make sure that is done. The second thing is the OGN has started a blood transfusion. After some time, she calls you and tells you the patient is passing red-colored urine. So what is your diagnosis? How are you going to manage that?
The immediate hemolytic transfusion reaction. It can occur immediately after the transfusion or within the transfusion, and it causes the hemolysis. Then RBCs will releases hemoglobin, in which hemoglobin will precipitates and acid hematine will accumulates in the distal distal tubules of the kidney, causing mechanical obstruction of
Very good. So how do you manage this?
Immediately, we should stop the transfusion and adequately hydrate the patient to maintain a urine output of 75 to 100 ml per minute. And IV crystalloids can be given along with injection mannitol. If mannitol and crystalloids are not responding, then we can start loop diuretics like injection furosemide. Then send the sample for a repeat cross matching to see whether any cross matching any reaction occurs, incompatibility occurs.
Yeah, very good. So now we have a scenario where we have a patient with multiple pregnancies, chronic anemia. You probably have given her IV iron with blood transfusion and you made her hemoglobin 9. That is the target you are looking for. The patient is coming for delivery. The obstetrician asks you, shall we proceed with a normal vaginal delivery? You're happy with it?
Yes, sir.
Yes, you can allow normal vaginal delivery. But whether you allow, are going to give analgesia or you're going to give anesthesia, there are certain goals that you have to follow during that period. What are the goals that you're going to follow? They are basically, you have to keep the demand of oxygen low and increase the supply. So what are the things you're going to do and what are the things you're going to avoid?
We advise a delivery with a labor with a epidural analgesia. Our goals are to avoid hypoxia, to minimize blood loss, and to increase the cardiac output, to maintain cardiac output during the labor time. Hypoxia can be avoided by giving supplemental oxygen during peri and postpartum period. Then we have to give the patient left uterine tilt.
Yes.
Then we must keep the patient warm. With the help of epidural analgesia, the hyperventilation that
where do you want to keep the ODC? Where do you want to keep the ODC? To the right or to the left?
To the right.
Okay. To keep it to the right, what all will you do? What will you do to the temperature?
Normothermia has to be maintained.
You have to maintain normothermia. What will you do to the pH?
It should be acidotic or normal pH.
Will you use prilocaine in this patient? Will using prilocaine in patient cause any problem to the saturation?
It can cause methemoglobin.
So you want to avoid that. You want to keep it normal hemoglobin and you want to keep it fully saturated. Okay. And you want to avoid sympathetic stimulation because this patient can produce tachycardia and increase the oxygen demand. So what are the things during labor that can produce sympathetic stimulation?
Pain during labor.
Fever, shivering, all that can produce. Okay. So let's assume we want to do a vaginal delivery and I'm asking for labor analgesia. How are you going to do that?
We will give epidural analgesia at the level of
whenever you answer in an exam, always start at the beginning. Okay, this is a high risk patient, oxygen delivery is likely to be a problem, so start with your IV line and what monitors you're going to put, and all that is more important. Okay, so don't hurry. I know you know all that, but in an exam they would expect that answer from you. Okay, start from the beginning. How are we going to do labor analgesia?
So we first see the patient. We do a thorough examination. We see whether she's having any spinal tenderness or
all that you have seen. You brought her in. What monitors do you want on the patient?
So we put the routine monitors like ECG, NIBP, saturation, then respiratory rate, heart rate, and urine output. We can do. The patient is going for
and fetal heart monitoring. Don't forget that also. Okay, that also is critical for us. Okay, then.
After that, we will put the patient. We will secure two wide bore IV cannulas.
Okay.
Then we will correct if any hypovolemia is there. We'll ask about NPO status of the patient.
Okay.
Then we will provide her with anti-aspiration prophylaxis. We give her a left uterine tilt.
Okay.
After doing all this, we'll put her on supplemental oxygen. After the patient is stabilized, we will put an epidural.
What do you like to do? Sitting or lateral epidural?
Lateral epidural.
Okay. Do you like LOR to generally sitting? Some people prefer, because in pregnancy the landmarks might be a little difficult if you put them on lateral. But if you put them on lateral, the advantage is the aortocaval compression is much lesser. Okay. And nobody needs to support a sitting patient. You need some support. In this, it's a little easier. So which space are you going to go in?
We will put the epidural catheter at the L2, L3 interspace.
Needle or catheter tip? Needle, where are you going to put?
Needle L2, L3 we will put.
Okay.
Needle in the L2, L3. And
your technique is LOR to saline or to air?
Air, sir.
Which is better? Which is recommended, air or saline?
Usually do air in our institute.
Very good answer. Perfect answer. You only have to do the technique that you are trained in. Okay. Although there are advantages of doing saline, you just have to tell them, in our institute, I'm trained to do with LOR air. I'm quite confident about it. Okay. Nobody can argue with that. Okay. How much of a catheter is going to go in?
3 centimeters of the catheter should be there in the epidurals.
I would probably push it above 3.5 centimeter. Between 3.5 to 6 centimeter will be good enough. Okay. What's your test dose?
We'll give a 3 ml, 2% lignocaine with 1 in 2 lakh adrenaline.
Come back again and tell me that again. Test dose again.
3 ml, 2% lignocaine.
You go, please check up. What is your test dose according to the textbook? Okay. So,
according to textbook, it is 3 ml, 1.5%.
You better tell that in exam. Okay, because all examiners know that. So you please tell that in exam. 3 ml of 1.5% lignocaine with
1 in 2 lakh adrenaline.
That is roughly about 15 microgram of adrenaline. Okay. After the test dose, how are you going to establish analgesia for stage 1?
Analgesia for stage 1, our plan is to give 0.125% of the 0.125% bupivacaine with 2 microgram ml of fentanyl.
What segments are you planning to block for stage 1?
During first stage of labor, the pain is felt in the T10 to L1 segments.
Very good.
Here it is blocked by giving 10 to 15 ml bottles of 0.125% bupivacaine.
This 15 ml, does it include your test dose or exclude the test dose?
Excluding test dose, sir.
So 3 plus 15, totally you'll give 18 ml? It'll be a little too much, I think so. I think totally 15 ml should be enough to block that. Otherwise, you'll have a wider block. So good enough. So what will you monitor intraoperatively?
We will look for we will rule out local anesthetic systemic toxicity. Then we'll monitor her vitals, heart rate, ECG, saturation. We will.
If she develops hypotension.
EP.
If she develops hypotension, your drug of choice.
Phenylephrine is given 50 to 100 microgram because it causes less fetal acidosis compared to ephedrine.
For second stage of labor, what segments do you need to block?
S1 to S4 is S2 to S4 is recommended.
What drug are you going to give for the second stage of labor?
During second stage, we'll put the patient in head-up position and give a 5 to 10 ml of 0.125% bupivacaine to my plus.
Fair enough. Okay, you can give the same solution that you were running. Usually it works. If it doesn't work, you can just give an additional bolus of narcotic. It should usually take care of it. Okay. Now we have done, if this is how labor analgesia works for this patient. If this patient comes up for emergency LSCS, okay, madam will take you forward with a discussion on the LSCS. Okay, madam.
Okay. Suppose this patient is taken for emergency LSCS. How will you proceed with the anesthesia?
First, we'll preoperatively we'll go see the patient. We'll confirm the NPO status. We'll look for the consent. Then we'll ask the obstetrician to give anti-aspiration prophylaxis, which includes IV ranitidine 50 milligram IV, then metoclopramide 10 mg IV, and 30 ml of 0.3 molar sodium citrate. These are the anti-aspiration. We'll put the patient on supplemental oxygen. We'll give her a left uterine tilt. We'll secure two wide bore IV cannulas.
So where are you keeping the patients?
No, in your institute, do you actually start 2 IV cannulas for your OG patients? Between you and me, do you start 2 IV cannulas? I also don't start, man. We'll start 1 good IV cannula. If you need, we'll start the other one. Okay. Okay, proceed.
After that, we'll.
Sir, usually what happens is if the patient is in the labor room, most probably when it comes to the
start one and we'll start one here. Okay, correct. I agree with that. Yeah.
They will be putting a new one.
Okay, madam. Yes.
Okay. After then we'll set the OT temperature. Then we'll check the anesthesia machine suction. We'll keep all the anesthetic drugs and emergency drugs ready. We'll keep the difficult airway cart ready, which includes different sizes of masks, then oral and nasal airways, different small size endotracheal tubes. Short.
Okay, Afra, stop. Swati, you want GA or RA for this patient? What are you going to do?
Yes. Okay.
If the hemoglobin level is more than 8 grams,
you asked for 9. I've given you 9. You asked for 9. Okay. So what do you want to do?
If the patient is having more than 9 and the patient is hemodynamically stable, we can go for regional anesthesia.
Okay, madam. You discuss regional with her.
Okay. What regional anesthesia will you give for this patient?
If she is stable, we can give spinal anesthesia with 0.5% of
the patient is already having an epidural analgesia, isn't it? The epidural catheter is with. So what you will do?
Extend the block by giving bolus dose of 0.5%.
Yes, you can continue with the epidural analgesia itself. Have proved that the epidural analgesia has worked as the patient is not having any pain, isn't it? So you can continue with the epidural anesthesia itself. So what is the dose of drug that you have used?
For giving anesthesia, we can give 0.5% of bupivacaine.
Okay. So what's the advantage of this epidural anesthesia?
We can, if the patient is going for cesarean session, we can convert this analgesia to anesthesia, and then we can
avoid polypharmacy associated with the GS.
Airway manipulation we can
and also we can continue with the postoperative analgesia also, isn't it? So, okay. Suppose if the patient comes as emergency cesarean section, and if the patient is not having the epidural catheter inside, so what anesthesia will you prefer? Emergency cesarean section.
If the patient is stable, we can give spinal with 0.5% of bupivacaine heavy.
Would you add something to your spinal drug? Hyperbaric bupivacaine.
1.5 ml of 0.5% bupivacaine with the
1.5 ml. That's what you put in your institute. You put 1.5 ml normally.
Along with that, we can add opioids.
What opioid?
Fentanyl can be given.
How much fentanyl?
20 to 25 micrograms of fentanyl.
What does addition of fentanyl do to the spinal anesthesia?
It decreases the dose of the local anesthetic, and also it can decreases the pain due to visceral manipulation.
What is that? It's called improves the quality of the block. Okay, when they exteriorize the uterus, that kind of difficult feeling that the mother has, it kind of blocks it. But will fentanyl produce good post-op analgesia if given intrathecally?
Same duration of action.
Very good, very good. It does not do anything more than 4 hours. So if you wanted to add a drug into the spinal space that could produce post-op analgesia, what would you add? What can you add?
Epidural,
No, epidural, no, spinal.
Intrathecal.
Yes, correct. Tell me, what morphine? You can add preservative-free morphine. Preservative-free. How much? 100 microgram. Okay, 100 microgram. So fentanyl does not produce prolonged post-op analgesia. Morphine provides prolonged post-op analgesia. What is the problem of giving intrathecal morphine?
Delayed
Can cause
respiratory
delayed
depression.
Very good, very good. Why does it produce delayed respiratory depression?
Because it is more hydrophilic.
Very good.
In the CSF and it causes a
It
delayed.
produces rostral spread because it's hydrophilic and can cause delayed respiratory depression. So you have to monitor the patient properly. So that is one very important point. Madam, if this patient came for an emergency GA, she refuses regional anesthesia. Kindly discuss that also of madam.
Okay. Suppose if the patient came as a rushed to the theater and saying that the patient is having some fetal distress and all, how will you manage the patients? What is your plan of anesthesia then?
We'll give her general anesthesia.
Give her general anesthesia. We are watching.
General anesthesia with
positioning of the first we start positioning of the patient should be, if the patient is in supine position, it should be kept under the right buttocks to avoid or
have to rapidly assess the patient previously whenever you accept the patient for surgery, isn't it? The patient is rushed from the labor room to the theater, isn't it? So you have to rapidly assess the patient and then
start pre-oxygenation.
Then you have to
Doctor, always, whether you're doing analgesia or anesthesia, monitors first in an exam. Okay, very, very important. You're going to give GA. Is GA difficult in obstetric patient? Is it challenging?
Yes, sir.
For several reasons. And now your patient is also anemic. Okay, so you have to get your monitors right.
Monitors will attach all the monitors, which includes ECG, NIBP, SpO2, EtCO2, temperature and urine output monitors are kept. After that, we'll pre-oxygenate the patient adequately for at least 5 minutes. Since the
if you don't have 5 minutes, or are there any other methods to improve pre-oxygenation?
8 vital capacity breaths with 100% oxygen, and also we can keep nasal cannula with more than 15 liters of oxygen flow to prolong the apnea time, since the patient is having low FRC and increased oxygen, increased demand.
Head up.
Head 30 to 40 degree head up in a 30 to 40 degree head up position. Okay. Our plan is induction with modified RSI.
We can continue with modified RSI, rapid sequence induction and intubation. For that, induction should be done with titrated doses of the induction agent until the patient gets unconscious. So if the patient
what drug would you like? Which induction agent are you choosing?
If the patient is hemodynamically stable,
stable.
Thiopentone sodium of 2 to 3 milligram per kilogram can be given. And if the muscle relaxant of choice is injection succinyl of 1.5 milligram per kilogram, and a rapid sequence induction with cricoid pressure of 10 Newton when the patient is awake, and it increases to 30 Newton when the patient goes for unconscious, and intermittent positive pressure ventilation of with pressure limiting less than or equal to 20 centimeter of water can be also given in modified RSI. And laryngoscopy should be very quick, and if it is suboptimal, we can release the cricoid pressure, and smaller size tube is always preferred as the pregnancy causes anemia. Once the patient is once the cuff is inflated, then only we should release the cricoid pressure. And anesthesia can be maintained with inhalation agents.
What are the options for relaxants apart from succinylcholine?
Rocuronium can be given at a dose of 1.2 milligram per kilogram.
What is the ED95 of rocuronium? 1.2 is 3 or 4 into ED95? Rocuronium, you said 1.2 milligram per kg. You know, is that 3 into ED95 or 4 into ED95?
4 into ED95.
Very good. Correct answer. Saxamethonium, Swati, you said 1.5 milligram per kg. Is that 3 into ED95, 4 into ED95, or 5 into ED95? What is the ED95 dose of saxamethonium? Homework. Okay. Find that out. Okay. Okay. Now, in that previous case, epidural, you said you will give epidural analgesia. Now, in this GA patient, how are you planning to give analgesia post-operatively?
GA patient analgesia, we can give intraoperatively, we can give opioids after the delivery of the baby. Then we can give IV paracetamol can be given. Then we can give local infiltration of local anesthetics can be given, or bilateral tab block can be given.
Very good. Tab block is a good option. Okay, you can do that. Okay. And multimodal with paracetamol, some amount of narcotic can be given. Madam, are we on time or we have some other time left?
We are crossing the time.
Okay. No, yeah, we'll just wind up. There was one question. That formula that you used for calculating the iron requirement intravenous that had a factor 0.23. You remember that?
Yes.
Can you tell that formula again slowly? One doctor wanted to know that formula again. Slowly.
15 minus hemoglobin into body weight into 2.23.
Okay, doctor, kindly call them up and check them out.
Replenishing iron stores.
Okay. I think we have covered anything. Anything else that's left, madam?
No more postoperative bleeding. That's the one that is. So because it is one of the important complications of anemia. So how will you monitor the patient in the immediate postoperative period? And suppose if the patient is developing bleeding, how will you manage?
A patient should be watched for postoperative bleeding in the ICU or recovery room, and because there will be increased chance of uterine atony and postpartum hemorrhage in anemic patients, and it should be managed with IV crystalloids, and blood transfusion if necessary.
Is there any drug that you can give in a bleeding patient that might help in decreasing bleeding?
Tranexamic acid can be given.
Very good. Dose?
15 milligram per kilogram, 15 milligram per kilogram.
No, agree. Okay, madam. Kids did very well done. Only thing is, when you start answering in an exam, any case, anesthesia, start with your IV line, monitors, fluid. Okay, don't jump to anesthesia straight away. Second, saying, I don't know the answer for that question is perfectly understandable. It's an acceptable answer. If you said you don't know, you just tell them you don't know. Third, if you get stuck and the examiner disagrees with you, just tell them what you follow in your institute. Our institute protocol is this, and your internal examiner will save you. Okay. Okay. All the best, kids. Thank you very much. All the best.
Okay. Okay. Thank you very much, sir.
Thank you.
For this. Okay. And also I express our sincere thanks to the ISA Kerala for giving us a chance to present the topic, as well as my students also. Thank you.